Thank you for joining us for this episode. Today, we're joined by Dr. Natalie Chai. We're going to be speaking about myopia management for Emetropes on the Myopia
Optometric
podcast.
Insights Media proudly presents the Myopia podcast, where we give you the latest myopia research, clinical topics, and industry insights. Make sure to subscribe to stay up to date on all of our awesome myopia content. And now to our host, a massive myopia manager himself, Dr. David Kading.
Thank you for joining us for this episode of the Myopia podcast. Today, we're joined by Dr. Natalie Chai. Natalie, it's awesome to speak with you. Thank you for joining us.
Thanks for having me. Yes.
Natalie, tell us a little bit about your practice. You practice in Edmonton. Share with us what you do in practice around myopia.
Yeah. And so I do have a specialized clinic, similar to yourself with myopia management. And I call it the trifecta because in addition to that, I do have a dry practice and especially contact lenses, and they do run together very nicely. I started specifically specializing in myopia management basically 2 years ago during COVID. And, at the beginning, it wasn't picking up as quickly as I liked it to, but now it's really taking off with families and kids now. So
What made that change? Like what actually there's two changes. What made the change for you to start doing myopia management? Let's start with that one.
Yeah, absolutely. And so being a high myope myself has always been a passion. So that was a big one for me personally on a personal level. The other thing was actually, again, personally, my nephew, I was watching him. He's 11 now, but he was changing crazy in terms of his prescription every single year. I saw him starting at the age of 6. And so I couldn't do anything. So that kind of just prompted my journey into exploring more into the options nowadays. It's pretty crazy how that's changed. The other thing too, I would say is obviously COVID with, screen time and kids being in school online. I think we've seen a huge uptick in say myopia or early onset myopia now. And the other part too is that at the beginning of it all, it was all planting seeds, having conversations with parents, even though they weren't going to move forward with it yet, but it's in their heads so that now 2 years after we had that initial conversation, they're coming back saying that, hey, we're now ready to do whatever it is for myopia management now. So it's 2 years after, right? We had the initial conversation.
Yeah.
So I think, time's better now, I suppose, or they're ready essentially.
Is that what you attribute to the real growth that you've seen in the last couple of months or year? Is that you planted seeds?
I think so. It's all about conversation awareness because a lot of families and parents don't even know. Number one, myopia is a disease, right? That's the keyword, disease. It's not normal. And two, that there's options around it that we can now manage it as well. So having awareness is probably the biggest thing, I think, is a lot of the patients that are coming back is the conversation I had a year or two ago as well.
Yeah. Well, I think that one of the big changes for me, and I've done myopia management since 2004, but I really wasn't until I said it was a disease. And once it became a disease, it changed for me. And I think there's still a lot of people, even that listen to this podcast, who, it's an inconvenience condition. And once you get to the point where you're saying, hey, this is a progressive disease, that in and of itself isn't the big issue, but what it leads to can be, so much more is, high blood pressure causes so many problems down the road, right? And this leads to so many problems down the road and increases your risk. I mean, when was the last time in clinic you saw somebody that was over the age of 70 who it was a high myope, who didn't have some retinal pathology? I think when we start looking at it from that side, start realizing it's the disease, we can't stop talking about it. And I had Ty May on, and one of the things that he said, and I totally agree with him, is talk about myopia with everybody, grandmas, grandpas, kids, parents, everybody, uncles and aunts, right? Yeah. Because they may have a nephew who got a pair of glasses from their eye doctor and, like you just didn't know there was anything to do. And then they haven't met the Natalie Chais of the world who are slowing down and stopping progressive disease.
Right, right, absolutely.
Yeah, key stuff. So, one other thing that I think is that is a game changer in our practice is when we start incorporating axial length. And I've got a whole perspective on axial length, which I'll share in a moment. But it sounds like that was a game changer for you as well.
Yes, yeah, absolutely. It was so funny because yeah, axial length, in my opinion, again, I believe is should be the gold standard when it comes to, my manage. But even so, prior to getting an axial length instrument, is that you can still practice myopia management without it, right? That's the
Mhm.
beauty of it. But the axial length has changed the way that I have practiced in terms of how aggressive I should be. I think that's the biggest thing for me, how aggressive we should be, and also how successful are we currently with the current option that we have, right? And do we need to shift or do anything different down the road because of, say, the child's eye axial length is growing a little bit more, a little more aggressively than we'd like it to. So I think that has been the biggest game changer for me. And
Yeah.
parents, again, understand it, I think, in that realm more so than, say, sometimes with prescription, right? As well.
Yeah. So you nailed it on the head with where I'm at, as I find that in the world of myopia management, we have people who are axial lengthists. And they're the people who say you can't practice myopia management unless you have one. And I know where they're coming from.
Right.
Um, but I slowed down a lot of myopia. I didn't know how much axial length I slowed down before I had a machine, but you don't know what you're missing until you get one.
Right.
And I don't think it should be something that keeps you from starting if you don't have axial length. You did, I did. We both got started and we slowed down the myopia and we liked what we were doing with myopia management. We saw that it was working. We became believers and then we further advanced. And I always use the analogy of glaucoma, right? Until you had an OCT, you really didn't know what you were seeing, but you
Exactly.
reduced pressure for patients and you seemed like you were stabilizing visual fields. So you thought you were doing something. When you got an OCT, you knew you were doing something. And not everybody is ready to do axial lengths. And I know you have a myopia, you have a IOL master,
Yes.
and it's a standalone machine. Not everybody has space for that. But I think, Natalie, and maybe you'll agree with me, as time goes on, we'll see more of these instruments that do multiple different things.
Yeah.
Like the Oculus Myopia Master is available now in the United States, and it does auto refraction, auto Ks, and axial length. And so, somebody comes in, you do an auto refractor on every myopia patient you have.
Exactly.
Why not do an axial length on it as well? And I think we're going to continue to see those machines come out. And
Mhm.
as more of us doctors are replacing our topographers or our autorefractors, we can buy those instruments. But I commend you. Obviously, the IOL Master is a great machine that has been really helpful. What what are some of the things that when you look at the axial length for your patients that really kind of stick out? You've posted some of this on your social media about some of the, some patients that you've had with their axial length. I look back on one where you overlaid some topographies on top of the axial length and showed, this patient had a 25 millimeter axial length. What are some things that stick out to you?
Yeah, no, absolutely. Actually, there was one that really sticks out with me too, is that I had this one patient, emetropic, or seemed to be, did a axial length measurement, and the axial length was 26 emetropic.
Mm,
So you're thinking like, hey, the corneal astigmatism, the lens is, basically canceling that out. But you're like, hey, this kid at 7 years young, he or is at a huge risk factor for retinal attachments and a gamut of other future diseases here. So it sparked a conversation with myself and parents to be like, this is not normal, right? Even though your child is emetropic now, right? um, and say, hypothetically speaking, if he continues to be okay with this prescription, but the axial length is going to continue to grow. He's 7. He's got at least, another 10 years of growth left, and it's going to continue to go. So that was big. So that actually kind of got the parents at least thinking about doing something preventative, right? So we're not obviously correcting for vision now. We're actually now specifically helping the preventative measures of the ocular health as well. So that was actually just recent. I'm like, this is crazy. Like,
what are you doing for preventative measures?
yeah. So right now, the easiest thing, and of course, when we're talking about, finances, insurance, right, is a big one too. We have to always have a conversation about what's covered, right? Is low-dose atropine. That's what I'm doing. It's easy for the kid. It's because just one drop a night, right? You don't have to have the headache of, wearing glasses, especially from a kid that has never worn glasses before. Why does he need glasses now? Contact lenses as well, especially for a young kid that's not ready for putting in contacts in the eyes. It just kind of takes that away. The other part too is, with I do use a lot of the Hoya MyoSmart lenses at the moment too. And so they do have an emetropic, option as well. So I do present those two options right now for preventative measures.
So this Emetrope's probably not going to be wearing contact lenses, right?
Yeah.
But you would prescribe atropine to somebody with a large axial length but zero refractive error.
I would.
Why they don't have myopia yet? How can you do myopia management in somebody who doesn't have myopia?
Right. Yeah. And so this is the conversation, as you probably had a lot with your parents as well, is that we're treating not the myopia, but in my case, the principal purpose is to treat the growth of the eye. That's coming. So I say it's not now, but it's coming. Like in a way, I see axial length kind of like a looking to the future a little bit, slightly. So I say it's coming, all right, and I pull up, the normative graphs that is available to us, and I say this is what your child should be 50th percentile or lower, but he's in the 90th already at his age range, and it's not good, right, in terms of the health aspect as well.
So presumably this patient came in, the one we're talking about, for an eye exam, just an eye health check to make sure everything was fine. Was that what they came in for?
They came in for their routine exam. And for me, in my practice, I do have my patients, pediatric patients, have baseline axial length at every routine exam. So that's what I do.
And the crazy thing about this is an instrument that is a standalone machine. It'd be like doing a very quick visual field screener on every patient, but this is another machine. And who would think, unless your protocol specifically said, to do axial length on an emetrope? Like most of us would have no thoughts of doing that, and look at potentially what it really brought up for you. It's very interesting. So when it comes to axial length numbers, what do you have some charts that you look at to reference for yourself? Axial length is in the really deep myopia world. People understand that 26 is long, but many of us have no idea what those numbers were. I presume you had no idea what these numbers meant 3 years ago, right? Before you had the machine. What are some of the numbers that you have in your head for benchmarks, or are you always looking at a graph?
I'm always looking at a graph, always, just because, as you know, and I can't remember just off the top of my head, but I can certainly, share. You could just Google it essentially, right? So there's graphs on European kids, right? And then there's also graphs for Asian kids, the demographic on that, because those are two very different demographics when it comes to axial length. And so I always pull up the chart all the time because it shows, because when I'm looking at it, I'm looking at it too, just to kind of look at where they're at growth wise. And it's also, again, impactful when I show it to the parents as well. So I always have to show it to them, because this is where your kid is and this is where they should be. But in terms of numbers, right? Honestly speaking, as you know, I don't remember too much because there's so much other things I have to remember in my mind. It's just easy for me to pull up a chart and be like, 9 years old, this is where you should be at, and kind of follow it every as well. So, but I
Yeah.
mean, we know, 24 is kind of even the average for like an ametropic adult, for instance, right? So, ideally speaking, for a child, it should be less than or equal to, right around there. So anything that's a little bit higher than that, the yellow flags and the red flags come up when I see those numbers right off the bat.
Yeah. So some of these newer instruments that are coming out, they have these normative graph charts built in, which is just beautiful, right? That makes it easier and easier for us. And but there's plenty of those charts available online that you could graph the child's age to their refractive error and see where they should be, and then look at the normative charts. What signals to you in the axial length world that the treatment that you're doing is not as effective as you would like? Is there something that kind of points out to you like progression still happening faster than I want, or I should intervene more aggressively?
Yeah, and so that's a great question. And so, because as you know, axial length and refractive error is not one-to-one, so that's the tricky part to it too. But I have my patients coming in, especially at the beginning of treatment, every 3-4 months or so, just to kind of see what's happening. So tight follow-up schedules, and at every follow-up, we do axial length. If I do find that there's a 0.1 millimeter change, that signals to me I have to look into something a little bit more aggressive. And I certainly will have a conversation with the parents if there's a change in the axial length, as well as a 0.5 or greater change in refractive error at the same time. So it's if both of them change, because it's possible that the refractive error change, but the axial length stays relatively stable, and vice versa, right?
Right.
So when both of them change in the same direction, that's where I'm saying, hey, we might want to add, say, low-dose atropine if they're only doing, say, ortho K, just to really have that double effect, right? Or, if they're not compliant, say, with their glasses, maybe we might want to consider, say, again, low-dose atropine, or, a contact lens option, for instance, right? So changing modalities as well. So that's kind of how I determine whether or not we need to shift our angle or perspective, or do something a little bit more aggressive.
Yeah. Yeah. So, as somebody just starts off in axial length world, they've got one data point. And as soon as you have two data points, you have a line. And when you overlay those lines on top of growth charts, they kind of start to influence where you would expect somebody to be. And having that third line really speaks to what's going on. So having a 3-month, or worse, a 6-month, which we would highly suggest at least a 6-month, if not a 3-month, for those overviews, especially when you're starting treatment, to really see where things are gauging. And what we hope to see is, as those growth charts are going up with an age for a specific myope, say a -2 myope, where you would expect that axial length to be, you can kind of see that these growth charts are changing with our treatments. And that really, speaks to it. Having this 0.1 category is a really good idea as well. If you see a 0.1 change over the course of a year, that would be somewhat normal. And really, that's more normal for teenagers than it is for younger kids. But if you see a 0.1 over a 6-month time period, that probably means more aggressive treatment is indicated, just like you said. So I think that your categorization really speaks to it. The difficulty is that if you look, and there's a great study that's on this, and I apologize to the authors, I can't remember who it is offhand, but looking at different ages of the individuals and how their axial length changes as it slows down as we get older, but in those younger years, normal change is more. And we know that growth is going to happen, right? If we see a 24 at a 7-year-old, that's a problem, because that's what an adult should be, right? So
Yeah.
we know that that growth is going to continue. So it really kind of speaks to, we need to look at those growth charts unless you have those numbers at the forefront of your mind, which who can remember all of those for every single age, right? The pediatricians don't know what the height and the weight percentiles is offhand. Those growth charts need to continue to be on the forefront of our mind with things. So very, very good perspectives. I love this perspective around the emetrope and doing axial length on every kid. And a conversation I was having at the Global Specialty Lens Symposium around axial length. Somebody raised their hand and said, "Hey, we should be doing this in adults too."
Right.
Hadn't really thought about that, but yeah, right. We should know where the adults' axial lengths are so we can speak to risk factors, right? We see that patient who's a -8 or 9, and we start talking with them about risk factors for retinal detachments. And if you see flashes and floaters, well, what about the patient whose axial length is, a 27, but they're a -3,
Yeah.
right?
Exactly. Yeah.
So axial length is going to become a bigger part of what we're doing. Absolutely.
I'm glad it is, or it will
Yeah.
be. Mhm.
Yeah. Very cool. Well, I appreciate you sharing your perspective on myopia and axial length. And I think you and I both are in our infancy. You've been doing it a little bit longer than I have, but there's so much to learn. It's really exciting. It's pretty cool stuff.
It is. I know. What a world we're in right now. It's pretty fantastic.
Yes, yes. Knowledge is exploding. It's really great. So yeah, well, awesome. Well, thank you for joining us for this episode. It's awesome to hear from you. I hope we can have you back on the Myopia podcast another time. That would be awesome.
Absolutely. Thank you.
Yes. And thank you for joining us for this episode of the Myopia podcast. Make sure to like and subscribe and stay tuned for future episodes. We'll see you then.
This podcast was brought to you by Optometric Insights Media. If you enjoy our content, please leave a 5-star review. And don't forget to subscribe for more great episodes.